welcome to the first in our series of podcasts. This one is about international perspectives on homelessness. My name is Dr. Jihad Malasi, working closely with Tom Neumark from Porchlight. The homeless, like many vulnerable groups, suffer with marginalization, access to health and social care difficulties, and a host of other challenges. Please join us today and our fantastic panel from all over the world to talk about issues that really concern us and our populations. I welcome you and hope to see you at the subsequent podcasts. I am your chair for today, Dr. Jihad Malasi. I'm a GP, or for international colleagues, a primary care doctor. I'm an educator and I work as a committee member for NICE. So why are we here today? In essence, with the current cost of living crisis, fall in living standards, widening income inequalities, more and more people are facing vulnerabilities that could lead any of us down a path to housing insecurity, or in fact, homelessness. And wherever they may be, homeless and housing insecure people face unacceptably poor life expectancy, barriers, challenges, consider stigma, debt, long-term conditions, and obviously digital exclusion with the new, the advent of AI coming very fast like a train. And these are only some of the things that hinder our barriers, hinder our ability to provide good care. So our hope today is to provide commonalities, to seek fundamental challenges and share best practice with you as our colleagues. I will hand over to you, Caitlin. You each have 10 minutes, and then followed by Tom and then Joe. Off you go.
Awesome. All right. Well, hi everyone. As introduced, I'm Dr. Caitlin Ryus. I am an emergency medicine physician, and I am an assistant professor at Yale School of Medicine. So my research focuses on how we care for people experiencing homelessness and substance use disorders concurrently, particularly in emergency settings, and also how social policies shape that care and their health outcomes. In my off time, I'm also the vice president on the board of directors for a local drop-in center and resource center called DESK here in New Haven, and we provide food and support services for people experiencing homelessness. So anyway, I'm really honored to be a part of this conversation. So I'm here bringing the United States perspective on this one. The U.S. Social safety net is incredibly fractured. People experiencing homelessness frequently fall through systemic gaps between healthcare, housing, and behavioral health, particularly post-hospitalization or incarceration. So a major failure point often is discharging to the streets with no housing plan or follow-up or coordination of their care. And the way that intersects with sort of my clinical practice is that we often medicalize homelessness. So homelessness is often addressed through the emergency department due to visible mental illness or public intoxication. And so often individuals are transported to the emergency department as a way to divert them from carceral settings. However, even though it's better than jail, emergency departments aren't designed to address chronic structural issues like housing insecurity. And so after brief stabilization, patients are often sent back to the streets, and that cycle kind of resets. Some efforts that I've been trying to take on to address this sort of vicious cycle have been developing community partnerships, particularly with medical respite programs, so that we can refer folks directly from the emergency department to respite, or community crisis centers where they can have a bit longer stay, and also just strengthening collaborations with like street medicine and other community organizations to help bridge that gap. But unfortunately, as I mentioned, it's very fractured because services are so siloed, and each organization seems to kind of address a different corner of the problem, often with like different criteria, different funding streams, and thus different accountability structures. So I've seen so many patients turned away because they don't meet the qualifications for one program, or they're not stable enough for another. So what we really need to do is start aligning these systems around people rather than categories. Excuse me. But it does seem at this current moment that we are often moving in the opposite direction. The current political climate in the United States has been marked by very recent austerity and criminalization. So providers are competing for limited funds while serving the same populations. So this often undercuts collaboration and trust. And I'd like to see us move towards systems that incentivize more partnership instead of scarcity. And I mentioned criminalization, and this came up about a week ago. I think it was July 24th, where the federal executive order that came out introduced a new policy that shifts us away from housing first and away from harm reduction towards more institutionalization. So instead of housing and care, this executive order will push people into institutions through expanded civil commitment and forced treatment. And it revives this old idea that homelessness is best solved by locking people up rather than lifting them up. The executive order also has massive defunding for all harm reduction and other evidence-based policies like housing first. It also increases surveillance and policing, so more data sharing with law enforcement, particularly of medical records with law enforcement, and encouraging tracking unhoused people's health data, raising big red flags for like privacy and civil rights. So I guess I should end on something a little bit more hopeful, and because I do want to hold on to what's possible, that even in this climate, we are seeing local communities find ways to collaborate through street medicine and, like I mentioned, medical respite and flexible low barrier housing programs and organizations that really do deeply center trust and dignity. So the challenge at this moment is to amplify and protect these models while pushing back on policies that are making it harder to do that work.
As was said at the beginning, I'm the CEO of Porchlight. We're a Kent-based, Kent-wide charity. We work on themes around homelessness and around mental health. And we've been going for 50 years. And as a result, I think we have a perspective on these questions, which may be a useful one to share. We both see when things go well and maybe when there are areas for improvement. We see pockets of excellent practice, which maybe could be learned by other people within the system. Given that Kent is a large and diverse county, the first thing I think I would start with is around accessing health services in the very first place. I'll then talk a little bit about the quality of support that people get from healthcare providers, and then finally maybe some thoughts about the future and where we could go from here. So I think on the first point about accessing healthcare is to say is that this is a patchy area, and there are certainly people who do not find it nearly as easy to access healthcare as others. And I think this was touched upon in the last presentation, and we have similar and also slightly different challenges in Kent. We do see access issues, for example, around digital exclusion, as was mentioned in the beginning. We do have systems of inflexible appointments where you have to fit into a kind of very carefully defined way of living your life on clocks and so on, which isn't always in accordance with how everyone lives. Possibly harder to overcome is there are issues around stigma and people being excluded from services, people being told, for example, that they can't register at a GP because they don't have an address, or people being informally labelled as difficult and being told that they have to go elsewhere. I was talking today to someone who has to travel for an hour now to go to use their GP because their local GP has said they're blacklisted. This is not a formal policy that this GP practice has created. There's no system for review or appeal. They've just been designated in this way. And so if people are not even able to access these healthcare services, then of course it puts them at a significant disadvantage. Having said that, there's excellent practice in this regard in terms of healthcare provision that's placed within communities, that's offered in hubs. We run a service in Dartford, the Dartford Health Hub, which is excellent. It's much nearer to people. It's done on people's terms, and it's done in a way that people can access. Care navigators, peer advocates, people like that as well can be excellent additions in this area. Then if we talk about the quality of services, once again, I think it's a mixed picture. We do see missed opportunities when we work in healthcare. We see times where people are discharged straight to the streets. We see people being put back into precarious housing or into temporary accommodation that is unsuitable or far from their support networks, where there's very, very little chance that that housing will be sustained. At the same time, we see excellent practice, for example, the Pathways programme, and we have a step down accommodation in Dover, where the housing step on, move on process begins right from the beginning of people being entered into healthcare, where people, what's going to happen to you next? Let's make a plan straight away. Let's work together on this plan. It's actually an opportunity to improve people's housing situations and to help them to stay healthy once they leave the healthcare setting. I think as well as that, there's a question about how you provide these services. So I think Porchlight, we do our best and to provide what's known as trauma-informed care. And that includes in trauma-informed environments. And I guess that means starting from an understanding of, if you've been through traumatic experiences in your past, is this going to determine how you interact with people? And very largely it is. People are much more likely to want compassionate, consistent, kind support. And at our worst, I think as a system, we can provide transactional, oblique, hard to understand support, which can mean that people don't engage or can become frustrated or don't know how to navigate these systems. I think I'd also say, finally, in terms of quality of support, there is something about some people have complex and varied needs that aren't straightforward to put into clinical boxes. So, for example, if you have mental health problems and you also have substance misuse issues, does that mean each side is going to say, well, we can't work with you first because the other side needs to sort it out? You can't have your substance misuse support because of your mental health problems. You can't have your mental health support because of your substance misuse problems. That's just one example. You might also say, for example, people who are experiencing frailty-related issues, but much earlier in life as a result of their lifestyle, but then being told, look, this is only something that happens to older people, for example. So you don't fit neatly into this box. Again, excellent examples of where this is overcome, where we see things like mental health teams who are assessing substance misuse orders, delivering brief interventions where necessary, addiction teams who are treating less complex and common mental health problems, and so on. And we see this across Kent, that there's excellent practice here, but there are still people who are being told they fall through the cracks. I think finally, the thing I would say is about the future, and we know the NHS is now going through large-scale change. We have a new 10-year plan. We have reorganisations taking place. We know we're going to have more of an emphasis on community support, on preventative support, on neighbourhood support. There is a risk with all of this type of work. Well, is it inclusive health services? Just because it's preventative and community-based and neighbourhood, that doesn't mean it's inclusive. And in fact, there's a risk that it's more exclusionary. And what I would say is, as we address those challenges, I think we would benefit from involving people with experience of homelessness and healthcare provision in the design, in the delivery, and in the review of these new schemes as we develop neighbourhood health services? How are we being formed by the stories, the experience, the expertise of people who've been experienced these homelessness issues, who potentially see the world in a very different way? So this is something we already see throughout Kent, and that's, I think, been my theme of today, that it's great to learn from other countries. It's actually also great to learn from something that sometimes is happening just one town over.
Hi, thank you. Yeah, thank you for having me. My name is Joe Tay. So as Jihad has already said, I have worked as a GP in Edinburgh for many years, including in the homelessness setting. I'm a I'm a lecturer in St Andrews University, an honorary lecturer, GP academic, and interestingly spent 2 years as clinical services director of Forward Leeds and Addiction Service in England. And a year in San Francisco, just last year with the Homelessness Initiative in UCSF, and now in British Columbia in Vancouver, again working within homelessness settings. So what's really cool, actually really interesting, is being able to see all of this in just a very short time in the last 5 years, and seeing really how much we have in common. And I was just listening to Caitlin, and I kept listening to Tom, and I was like, yeah, tick, tick, tick. Completely agree, completely see all the same things. I just wanted to talk very briefly about a few things that I think we all already know, but it's no harm, I think, repeating these things. This community, people experiencing homelessness, they are extremely socially and socioeconomically marginalized. And not so long ago, a paper by Robert Aldridge showed that if you fall into this category, you have a chance of dying greater than 8 times than the person at the lowest rung of the socioeconomic ladder if you're male, and 12 times if you're female, if you're a woman. And that is just crazy. So we know there is a socioeconomic gradient in health, but for our population that we're talking about today, they fall off the cliff of that gradient. They're nowhere even near the bottom of that gradient. And that's crucial, because when we talk about providing care, and we talk about, for example, what Tom mentioned, that is hopefully going to be a positive thing, community-based care of more focus and community. We also need to remember that we need proportionate care. This is a group that needs a lot more than what we're giving them, primarily because the need is greater. But then reflecting on what Caitlin said as well about the changing environment in the US right now, we also need to remember that defining need is actually a value. It's not objective. It's very subjective, and it's values-based. People, our political system, ourselves, we all decide from moment to moment what is need. What does someone need? And is that need actually justified? We often make these judgments. Is it something that we should be providing? Is it something that another organization should be providing? And again, just this kind of siloing of how we define need and how we feel we should be providing that need. A common thing I used to hear was, we're not commissioned to provide that, but the person is still waiting there, having that need, So there's a lot of judgment calls. There's a lot of values-based judgments that need to come when we are, supporting this community. So I want to just make, I suppose, provide two examples of scenarios. One of them is around digital health, another big area of interest for me, and specifically looking at telemedicine around the pandemic and how it was used to provide support to people experiencing homelessness. Sometimes, we immediately think, well, this is something that will never work for this population. There is never, mobile phones that are charged, or the availability of mobile technology. Phones get lost, people don't like it, carers don't like it. But there was a vast amount of literature that was developed during the pandemic that actually showed many ways that it did work. And it all was based fundamentally around the people who were close to people experiencing homelessness. And the tool, the mobile phone, the computer, the laptop, the tablet, the pod, all of that was just simply a tool used to enable human interaction, human closeness. So things that we've already heard, for example, Tom mentioning care coordinators, outreach workers, people who are close to the person experiencing homelessness, who have trust, where trust has already been built. Being able to provide support to navigate complex systems was crucial. And we had examples where community-based workers would go out into, for example, encampments with a mobile phone, speak with a patient briefly to find out what their needs were. If someone needed, for example, methadone or buprenorphine, mobile phone was used to contact the specialist clinician on the other end of the phone, and prescriptions were organized based on obviously valid and kind of pre-planned pathways as to how you do that assessment. In the US, that was predominantly with buprenorphine, but the point was this was as low barrier as you could get, but someone was going to where the person is and trying to get this care to them. So I'm not going to go through every single model in here, but I guess the point is, if you look at things like technology as the tool and the person at defining what the technology should be used for, then we can really start to think more creatively as to how we can actually make systems adapt to what people actually need. I then wanted to quickly talk about the service I'm working in right now. So it's Ravensong Community Health Centre in Vancouver, British Columbia. And it's primary care. I'm a GP, and we have, this will shock you. Well, I'm guessing it will shock you. So as a full-time GP would have 100 patients. I have been a GP in Scotland where, yeah, we had a lot more than 100 patients. So I manage a caseload of 100 patients, all by definition having many complex needs, but defined also, sadly, by experiencing homelessness. It's team-based care, and this you will be familiar with, of course, in the UK, nursing, actually, I was going to say a whole list of things that you'll be familiar with in the UK, but in fact, now that I look at my list, I realize maybe not. So nursing, okay, that's about it. After that, we also then have care coordinators, an outreach team, not attached to the community itself, but attached to this service. So for this 100 patients, and we have nursing social worker to help 100 patients, care coordinators, administrators, an outreach team, wound care, foot care, in-house psychiatrists, counseling. Care coordinators spend a lot of the time contacting patients either directly by mobile phones or through their workers or through the outreach team to find them, arrange transport for appointments, for specialist appointments, for investigations, to make sure that they are receiving their medication. We proactively check in with them before prescriptions are due, particularly when it's for opioid use disorder care. If we can't find someone, we send out members of our outreach team who tend to be able to find out through others in the community where these people might be hanging out at this given time. If someone needs an emergency visit to the ED, the emergency department, one of our care coordinators will accompany the patient and sit with them to help overcome these feelings of trauma and fear that, from past experiences. Many of our care coordinators include nurses who will go out and do dressings, wound care, which is a massive need amongst our patients in this community. They also can do what we call OAT assessments, which is assessment for the need for methadone or buprenorphine. These are the outreach teams. And then some of the nurses in the team will either be able to do the prescription directly because they are so trained, or they can contact me or one of my colleagues to arrange that. We sometimes offer sufentanil, subcutaneous injections for very painful wound care, both in the community and within our practice. There's multiple options for opioid use disorder, including the methadone, buprenorphine, including injectable, but also fentanyl patches, long-acting morphine tablets, injectable diamorphine, and a powder fentanyl program. That's not offered through my service; it's just available in Vancouver. And pharmacies deliver medications directly to the patients, including methadone, buprenorphine, and including trying to locate the patients. And in fact, so they just simply because they do that, go and find the patient and make sure they get their medication. And this is our community pharmacies. The degree of concordance with medication can be quite high, which, as we know, is critical to making these medications work. We have challenges, of course, and housing being the absolute top number one. There's very little that we do that will have lasting impact without also addressing housing. and that housing needs to be acceptable and secure. There's the toxic drug supply that's out there, and this is a real tragedy. We're in the short time I've been here so far, we're really observing this. People aging out in the street, premature aging, spinal issues, disability, septic arthritis, and this perpetual cycle of wound care. People having to be on their feet really pretty much almost 24 hours a day sometimes, never having a chance to rest or heal. And storage, where do people keep things? I've had patients coming in with literally trolley loads of of their entire possessions, but also when they're collecting tins and cans to try and make money. Of course, they bring it into the consulting room. That's absolutely fine. But what about the rest of the day? And then of course communication and digital exclusion. Whether you charge your phone, how do you connect? How in the UK, for example, how do you access your benefits? With the digital first implementation, which has been, I think, now about 10 years. So these are kind of things that I've seen happen here. Nothing to do with me. I literally jumped into a system that already had these things. Well, it was really interesting to see, though, the different ways of thinking and what those different ways of thinking might lead you to do and lead you to intervene with. And that's it. That's it for me. Thank you.
Thank you very much for your insight. I can see lots of responses in the chat, and we'll try and come back to those. One of the things that really struck me about what you said was this heart-rending image of a trolley-wielding patient with broken feet, and bags and bags attached to the trolley, and that just, I mean, that's a sort of almost an archetypical Hollywood image of a homeless patient, but I think that is replicated all over the world. And it's it's something that I think we need to talk about more and more, really, to try and appeal to people's um, their emotional sense and to engage with homelessness as an issue. So thank you for that. You also touched on a number of very interesting things I'd like to come back to, like digital inclusion. As part of our work at NICE, we also do a lot of mental health related things that are related specifically to mental health inclusion. So another point to come back to, value-based judgments and so on. Again, that's a very big issue, and that ties in very well with what Tom and Caitlin have talked about today, about the financial, the political challenges, the data sharing elements, the nexus, if you like, between law enforcement and health and how we share that kind of information. All of these are really very interesting and prescient issues for all of us. In the first instance, I would like to reflect back to Tom and to Caitlin. Tom, would you like to go first if you have reflections?
I guess one reflection is how interesting it is that people who are talking about settings which are in different countries with different politics, with different funding, with different organizational architecture are starting from both we have a client group who are experiencing similar things, but also we have systems that have similar both challenges and also ideas for solutions. So if people are saying in different parts of the world, in different cities, yeah, we also have an issue with how do people even access the healthcare in the first place, with people being excluded. Yeah, we also have an issue with people not fitting nicely into boxes and people getting past pillar to post. And then saying, and here's what we're trying to do in the face of those things. And it strikes me that probably it's worth pausing for a second and thinking, well, why, given that these are such different healthcare systems, do we have these shared challenges and looks for solutions? And I wonder if part of it might be the way we design these systems is with an idea of what a patient is and how they're going to behave. And that when people aren't like that and are quite unlike that, we're stumped. And it is worth saying that. I think it's worth saying that, for example, in Kent, you might in a given month have, according to the government statistics, maybe 200 people sleeping rough. Now, that's only one form of homelessness, and that's not going to be everyone who's being counted as homeless either. There's many and varied ways that you can experience homelessness. But if you compare that number even if it's the bigger number, the number in temporary accommodation, that would be several, thousand new households. With the overall population who are using healthcare, you can see that why you would design a system that says, if you go to the GP, you have a 5-minute appointment. If you're going to be referred to the mental health clinic, you have an appointment, you have to turn up there on time, you have to present your issues in this way. You can see why systems would be designed with this almost industrial logic. And then you can also see a little bit of what Joe was saying, why those won't work for certain groups. They just certainly won't. People want to trust someone they know and work with someone that they trust. And if it's based on this kind of more anonymous, uniform way, there are going to be challenges. And so I think part of what makes it work, to the extent that it does work in Kent, and part of what we need to do is recognize we're not getting rid of that challenge. It's more, what do we do in the face of that challenge? How do we get that to work, I think. And I think these kind of conversations and sharing, this worked here, this works here, is useful to think about it. Not to say you can copy and paste because of those differences, but learning and thinking, well, they were able to manage something that seems so structural, that seems so impossible to bridge. People that don't fit into the box. No, I think it is, there are ways of improving things, but I think we have to start maybe from that. So there's a bit of a reflection from me.
Thank you very much for that. Yeah, Caitlin, I see you've taken your mic off.
No, it's so it is wild to think about the vast differences between these countries, and then the commonality when it comes down to our most vulnerable. That this is a population that in many ways has not been able to who has been failed by a lot of the mainstream structures, and to think that in their healthcare that they would be able to fit into this 5-minute appointment model is a bit absurd, because there's so many other ways in which that's not worked. Of course, that would translate to one's healthcare. But I also was really struck by the idea of having assistance be proportionate to the need, and that this is such a high need population, and yet we have developed a system that is reliant so heavily on charity and private organizations, faith-based organizations, rather than allocating real, like, tax-funded, structural interventions. And I think about how much frailty there is in this population that came up, and how much worse that's going to get. Right now in the United States, 1 in 5 homeless persons are over the age of 55. And of those sort of elderly, unhoused folks, half of them are sleeping rough. And even in the sort of, average adult population, you see diseases of aging 10 years earlier. So dementia and diabetes and heart disease this is a premature aging group. And so as our populations are aging, so is this population. So this high need population becomes more frail, more high need. So how do we address that? And it's definitely something that's already kind of struck our city leaders. We talk about sort of those time-limited problems where someone maybe has a broken ankle and so they need medical respite, right? So 3 weeks, some physical occupational therapy. Of course, you wouldn't be able to push a cart if you're on crutches, so we're able to provide some respite. But I recently had a conversation with one of our directors of housing that we now need some sort of respite, but it's not really respite, because we're talking about people with advanced renal disease, people who are unhoused with cancer, end stage. How do we start caring for people at that end of life section of this population? Anyway, that just popped into my head listening.
Yeah, they're incredible reflections, really. And I think about somewhat equivalent services here in the UK that we provide through health and not through other mechanisms such as social care or non-tax funded mechanisms like you clearly outlined there. SMI, physical health, patients with schizophrenia, bipolar, they have a national strategy with a national inequalities lead and a direct stream of funding through what's called a mental health investment standard, which is a standardized thing across the country. Learning disability, for example, patients with this longitudinal description of disease that you talk about, people coming to frailty at the end of life. All of these are funded through health, and I almost view them as quite similar in terms of their characteristics. There are clearly some differences, but as they get older, I think that there's an argument to be made about how we fund this and how we make that the case. Joe?
Thank you. Yeah, that's so interesting listening. And Jihad, I just want to pick up on something you picked up on, a thing that's really important. And that's the business case for all of this, we've already talked about, the values involved or implicit or explicit in directing resources and proportionate care. But there's a real hard-nosed business case here. The Black report in England pointed this out. Carol Black, I don't know if she said, for every £4, maybe £5 you invest, or is it the other way? Every pound you invest in services geared towards people with addictions, you save about £4 or £5 in return. And similarly, when we're talking about this group, one thing about what I was describing in Vancouver, and of course many people will definitely pick up on this, how much does all that cost? And I'll say I get 30-minute appointments at least with my patients, and actually our patients get as long as they need. So they could be there half the day, not necessarily with me the whole time, but we don't chase them out. So if they're in there, they're kind of a little bit intoxicated, they're not terribly well, we prefer that they're in our building so we know that they're deteriorating than out there on the street. So, I mean, this comes with a price tag. These are not cheap services to run. But when you think about what happens at the other end, if you don't actually, provide care proportionate to the need, then you have frequent emergency department visits. You have, people presenting much later on in their condition and illness and needing much more significant care. There's a description of this being demand failure. So where you're not meeting the person's need when they present and early enough, you have them then presenting in a place that is completely inappropriate to their more complex needs, and they're having to firefight and save a life rather than actually, intervene at a better time. And demand failure is incredibly expensive. And the next time you're in an emergency department wondering why you're waiting so long, well, there's your answer. We didn't intervene when we could have. And for this group of people, there's loads of opportunities to intervene well before it gets, as bad as it can be. And another thing that's not been really mentioned yet is keeping housing secure, to try and intervene before people actually become homeless in the first place, or really pay attention to unstable housing and the complex medical and social needs that lead to that instability in housing. And then also just within the same frame of the business case, also making a business case for not siloing services, not siloing funding, which by doing so, we silo risk. One organization isn't going to want to do certain things because actually they're carrying the risk with none of the benefits. Equally, another service is carrying all of the risk of one particular issue and are not going to feel able to expand what they do because they're busy trying to deal with this one thing that they've been put sole responsibility for. And so we've got a system really that's designed for us to think of a person's life in little packages, in little bits and pieces. That person, you, me, we don't think of our lives as little packages that we package out to different professionals depending on what our needs are at any given time. And for people experiencing homelessness, they don't experience complexity as a theory. Their whole lives are an embodiment of all this complexity that we put upon them. And simplifying those processes can only be a good thing, really. Thank you.
Yeah, it's very valuable, really. Tom, you've got your hand up.
Just very briefly, one thing that really struck me and always strikes me when I speak to colleagues working in health and medicine is that quite a few are aware of a concept of like missed opportunities around healthcare. So if someone's eyesight has really, really deteriorated, or if the cancer has really, really progressed. There was a missed opportunity when you look back earlier. We could have diagnosed this sooner. And actually, I think in an almost metaphorical way, what Joe's talking about there's a similar sense, I think, around homelessness. That when someone is coming in to seek help around their healthcare, that is a tremendous opportunity to see if we can make improvements in a wide variety of their aspects of their life, including their housing. It is incredibly expensive to have people who are homeless, and it's incredibly bad for them who are as well. And so if we were able to use the opportunity of someone coming forwards and saying, I've got a problem with my leg, with my kidney, with my teeth, to think, well, how is this an opportunity to help improve that situation? That could be a tremendously powerful way of thinking about it, rather than thinking, God, I've only got time to sort out this one thing they've got. I can't take on all the rest of it, because they're going to keep coming back. It's not like they disappear once if you just sort out that tooth, or if you just sort out that one issue. And so, yeah, I was thinking as Joe was talking about that missed opportunity concept.
I am going to be not controversial, but I'm going to reflect back this conflict between what the system and the philosophical notions of how we should treat people on a population basis versus the reality of having 10 or 15 minutes as a GP and trying to, in that individual, very personalized discussion, trying to affect change in a meaningful way for that person at that point in time. And I suppose if you draw back and you think that there are hundreds of small appointments and small interventions that incrementally make a difference to somebody's life, but within the context and the confines of that very personal discussion, it's very hard to see the big picture. It's very hard to see how you affect an overall change. And that's something I think that we should talk about a bit more, and how we link up those things. Perhaps digital and digital inclusion is a way of harnessing that kind of information. Is that something that comes across in your work? Possibly Joe or Caitlin, something you've seen in your academic work?
You mean the digital inclusion component?
Yes, perhaps.
Yeah. It was definitely much more prominent during COVID, and I thought it was really interesting how that period of time in New Haven, what happened is that the temporary shelters closed and folks were diverted to hotels, which were being unused because no one was traveling. And what was interesting about that is that the folks who were previously sort of like the service providers for shelters, were able to just sort of like pass an iPad from room to room so that people could have their appointments. And it was actually very accessible. And it was sort of counter to what I often hear as sort of the mantra when you say, well, what if we did a digital health intervention, or what if we did this by phone or chat? And they say, well, no one has phones, no one has phones. And I don't think that that's entirely true. I think that there's barriers to phones, like they may have prepaid plans, or they may have struggles with charging. And of course, there's going to be some phone diversion, but it's not like a non-starter. And I think that it again speaks to what Tom brought up about including people with lived experience in sort of the design and the evaluation, and that there are folks who are unhoused who would welcome a digital platform, and bringing them on how do you make that digital platform low barrier.
Very interesting. Yes, Joe.
And I just want to, I suppose there's two things. One is something that we've been lucky enough to have in Scotland and England for some time, and that is electronic medical records and increasingly linked data. So removing the data silos that separate social care from, social work, from hospital-based interventions and primary care-based interventions, linking those data sets and having the ability then to also act on the data that we have when we have a holistic picture. I mean, I think you can't have innovation, you can't have change without data. That's what those things are. It's how we respond to data that creates change. And caveat, we know, for example, right now, this data is being used against people. You know, all the protections that we believed we had when it came to health data are now being challenged in the United States, and actually have been also in England, although in the UK but to a different extent, with, I think, more pushback perhaps from health professionals. So that's the caveat of that, you know, how data is being used. However, I will say this, though, we have lots of bad examples of how algorithms and data have been used, in fact, to punish people experiencing homelessness, or perhaps more generally, people who are receiving benefits. You know, the whole idea of digital first, that you have to have the ability to log on and create an account for yourself to access benefits is a big disadvantage to people experiencing homelessness from the get-go. And that's been on the go for at least 10 years. So we're not too concerned about their digital access when it comes to something like that. And yet we seem to be when it comes to providing healthcare. So, you know, we need to think a little bit more about how technology is actually being used and whether it is to the benefit of the patient. It's largely not really about the technology, it's about the intent. You know, is it about surveillance or is it about care? And if it's about care, we find ways to make it work. If it's about surveillance, we find ways to make it work, but it's not for the patient. Yeah, the intent, I think, is key.
Yes, I had the great fortune to visit New Haven in 2019 and to visit a VA establishment. And the thing that really struck me, apart from obviously all the good care that you provide, was how data driven and how financially driven the system was. So the manager of the ward and the unit outlined in dollars and cents down to the cent exactly how much each intervention costs, and that was all put in a very clear spreadsheet. And that's not something that we have visibility of here. So, I mean, speaking about data and how we see money flowing through the system, obviously, I'm not suggesting that our systems are comparable in that respect, but perhaps there are lessons there to learn. Tom or Caitlin?
Yeah, no, I mean, I think it's the sharing of data and to operationalize it. I think that there's some very real potential. It's certainly something I do in my research. So what I do is I join people's electronic health records to their social services records. So I get their homelessness information system data, whether they stayed in a shelter or whether someone from street outreach has been going to visit them, or if they were provided rapid rehousing. And one of the things I always like sort of caution people about is that, you know, to do health outcome metrics or health services cost metrics, assigning those together, the first barrier is even joining in the first place, because many of those services are low barrier, as they should be, and that people don't have to provide their full name, for example, and their birth date can be New Year's Eve, and they can be Bugs Bunny, because they should be able to get food, housing, medications without that. But it does make it really hard to join those and to be able to demonstrate that cost and healthcare benefit. But it gets to what we were saying about what's the purpose of it.
Yes, very interesting. And clearly there are, you know, we need some safeguards as to how that data is used, and that confluence between, you know, data protection and law enforcement is that's something that's live in the United States, I imagine. Yeah. Um, I have two questions here. I
Sorry,
think,
Jihad,
sorry, Tom, yeah,
can I
Tom, come on in.
just want
Come
to
on in.
add a little bit more to that, and that is data is reductive as well. That's another thing that's really
Mm,
important to know or to remember when it comes to particularly our patient group. Their lives are often so complex, and there's so many complex needs. And the
mm,
problem with data is you're trying to narrow it down to certain outcomes. So what that means also is organizations then are not really incentivized to manage complexity. You know, if your outcome is I need to deliver under $20 this one intervention, then that's what you're going to go for. But actually the person needs 2 hours and needs 5 different things involving one person on the phone, and it's not even their job to do. how do you actually cost that in? So that's one caution about data. And then also when data linkage studies have been used for people experiencing homelessness in particular, and when algorithms have been applied to it, what they found is actually, really complex issues and needs are reduced to practically nothing because it involves matching that to what the system's able to deliver. So that's the other thing. Your data could be, as detailed or as abstract or very limited, but if you don't have a system that's built to address those needs, again, it's kind of limited use. And my worry about the focus on data is it's a distraction as well. I think it's essential and important, don't get me wrong. I think we need to know what we're doing, but we can't hang all our hats on it because it just becomes a distraction.
Yeah, very interesting. Caitlin, you want to come back on that?
Yeah. No, I also just, whenever I start talking about this, I always also want to like put in the premise that services that are provided automatically should be accounted for with healthcare savings. I just challenge that because maybe it is just the right thing to do and it's a cost that we should just pay for, and it doesn't necessarily have to translate into an economic benefit for the system.
Yeah. Tom, any reflections on those comments as a
I have,
provider of these
yeah.
services?
There is an interesting, a slight digression, but there's an interesting story that comes from the previous government's rough sleeper strategy. And so that was a national plan to end rough sleeping in England. And an enormous amount of time was spent coming up with a definition of rough sleeping. What would it mean to end it, and creating dashboards which are now freely available, and we can all go and look, and we can look by district, we can look by government region, we can merge them together, we can see the number of people who are new to the streets, we can see if they're leaving prison, we can see if they're repeat, we can see how long they've been on the street, and it is a marvel to behold. The charts are made automatically and you can see. But of course, rough sleeping increased considerably during that time as well. And so I do feel like we have a clearer picture now, but that's got to just be the beginning of things. It is not the be all and end all. And what's clear is you can create the data, but you have to respond to it as well.
Yeah, again, very, very valid and very important points. Yeah, I before we hit the last 5 minutes, and I want to sort of round off the conversation in the last 5 minutes with some positivity and, really the reason why we're here as a group of interested professionals and curious about the world and our various systems. So, but before I do that, I have a couple of questions. One is, and I'm sorry I can't see the name. It says, are people in temporary accommodation included in homelessness data and service provision? And what are the challenges and opportunities for better support for these groups of people? I think this may be directed to you, Tom, as we're in a local context.
There is a lot of excellent work for people with temporary accommodation. There are thousands of households in temporary accommodation across Kent, including thousands of children as well. And the Pathways Project, just as one example, do excellent work. The thing I would say, which probably is a data point as well, is there's temporary accommodation and there's temporary accommodation. A huge number of people are in paid nightly private temporary accommodation. Actually, throughout the country, the Travelodge is the 10th largest provider of temporary accommodation in England. Now, if you're in that situation, you might not know where you're going to be tomorrow night as a household. So accessing healthcare in that situation is very hard. Also, some of the quality is terrible to the point that it's hazardous, which of course is not good for you. Having said that, there's other people who are in temporary accommodation. They're going to be in that same building for several years while they're waiting. So of course you can access healthcare. There's a lot of other problems with being in that limbo state. I know there is a lot of work across the county to try and improve the situation around temporary accommodation. This is a big financial challenge as well as a kind of human challenge. But I would say there is good work in this area, but it's a structural issue in Kent that we have so many people in this TA, as it's sometimes known.
Yeah, thank you for those, Tom. And just a follow-on point to that, Jess Mukherjee, who is my colleague from Public Health, Kent County Council, and who has been in this space for a very long time, asks, who should be the lead commissioner for this client group? Re the whole system. I think what she's doing is she's speaking to really the fragmentation in the system, and actually who really has ownership. What are your thoughts on that, Tom, as somebody who's leading Porchlight?
That's a good question. I don't know if I am the best person to answer that. I think it is hard to get everyone in a system to all line up and
Mm.
and to work to the same kind of set of shared goals. And it would be great if things like social care, housing, and healthcare were more integrated. I think part of the lesson of the last few years is reorganizing things and giving them the title integration isn't of itself enough to integrate things, and that actually doing this integration is very challenging, and we maybe need to do a bit of reflection on that as we come to another round of reorganisation in both local government and in the ICBs and so on, that it's about the structures, but not just about the structures probably. I think there would be a risk, if we had one person, I'm the lead commissioner for complex needs throughout all of Kent, actually straight away, there would be lots of other people involved, and how do we all work together? It doesn't really go away as a question. So I'm going to duck that slightly and say that's hard.
It is hard. It is hard, Tom, and perhaps unfair putting you on the spot. But I think it's something we all need to think about, and I think it's one of those elephants in the room that we need to respond to in a way, right? Yeah, and if not us, then who's going to talk about it? So let's do it. Yeah, Caitlin, last reflections before we sort of hit the 1 o'clock mark.
Yeah, no, this has just been really great to hear that, not only are these problems more universal than we maybe are realizing when we're in our day-to-day work, but also there's just been some really great ideas that I hope to bring back to my partners, like delivery from pharmacy and like having people accompanied on their ED visits. I can just think about how many times in practice something would have been a better outcome had someone had a navigator or an advocate with them. So I'm going to bring that back.
Thank you for that, Joe.
Thank you. That's been a wonderful opportunity to join all of you and have this conversation. It just shows, though, how much there is to do, and yeah, hopefully there can be future collaborations. I would love that.
Yeah, I feel we have 1 minute left, but I feel we have only just begun to scratch the surface of what we could be talking about today. But I mean, some of the very big themes are, as Caitlin rightly said, around the financial and the political and the data information aspects of this. And Joe, obviously, you've outlined some case studies and how data management should be, ethically framed, really, and how we should use that data appropriately. And Tom, obviously, your insights into how these services should run. And I just think that we could do so much more out there in this world if we just talk to each other more often. And I hope that this will be the basis for a conversation that we can come back to again and again. I know there's pressures on everybody's time, and it is Monday. And I know you're all working very hard on a Monday, but thank you so much for being here, and your attention and your questions and time have been much appreciated. So thank you very much.